Good morning, Dr. Phil here. Today we'll be discussing on approaches to anesthetic considerations. The first is the chronological approach, preoperative, intraoperative, and postoperative. Pros includes logical sequence, mirrors the flow of patient care, making it intuitive to follow and ensuring no phase is overlooked. Allows structured planning, prepares the anesthetist for each stage of anesthesia from preparation to recovery. Focus on transitions, facilitate smooth handovers and continuity of care. For example, preoperative optimization, transitioning into intraoperative monitoring, and practical implementation, directly applicable to real-time clinical workflows and documentation. Cons includes limited integration of priorities. The anesthetist may miss cross-phase priorities such as fluid management that spans all stages. There is risk of compartmentalization. This can lead to oversights if factors from one phase are not adequately linked to another phase. It's not always dynamic. Emergencies or rapid changes may disrupt this linear approach. Next is the systems-based approach. Pros includes comprehensive evaluation, ensures all organ systems are systematically assessed, identification of multi-system interactions. This highlights how comorbidities in different systems interact and affect anesthetic management. It is customizable for different comorbidities, which is particularly useful for patients with complex medical histories or multiple comorbidities. It supports safe planning. It reduces the chance of missing critical systemic factors, for example, avoiding nephrotoxic drugs in renal dysfunction. Cons: it is time-consuming. It is more detailed, which may delay decision-making in emergencies. There is risk of overemphasis, which may lead to disproportionate focus on one system at the expense of others or overarching issues. Complex documentation is another con. It is harder to align with clinical workflows compared to chronological approach. Next is issue-based approach based on priority. Pros includes prioritization of critical issues, with focus on life-threatening or high-risk factors first, ensuring immediate concerns are addressed. For example, airway difficulty or hemodynamic instability. It is customizable, tailored to the patient's specific risk and surgery's complexity. It is efficient for emergencies and allows rapid decision-making under time constraints. There is better interdisciplinary communication by encouraging clear discussion of priorities among team members. Cons includes risk of missing details. Secondary or minor issues may be overlooked if they are not deemed critical. It requires experience and is less suitable for inexperienced practitioners who may struggle to determine priorities. There is potential for disorganization. Without a clear structure, it can lead to chaotic planning or incomplete assessments. The next approach is risk-based approach. It focuses on stratifying and addressing risks, high, moderate, or low risk associated with the patient and procedure. Elements includes preoperative, intraoperative, and post-op risk. Pros: there is a focus on mitigating high priority risks. It supports informed consent discussions. It ensures readiness for complications. Cons: this approach may neglect minor risks or rare complications and requires careful prioritization and experience. Next is patient-centric approach. This focuses on tailoring anesthetic management to the individual patient, considering their specific demographics, preferences, unique characteristics, comorbidities, and previous anesthetic history. Pros: this provides highly individualized care. It improves patient satisfaction and outcomes and encourages shared decision-making. Cons: this is time-consuming if the patient's preferences conflict with clinical judgment. This approach may not fully address procedural requirements. The next approach is procedure-centric approach. There is a focus on the surgical or procedural requirements to guide anesthetic planning. Examples of elements: type of surgery, with adjustment of anesthetic technique to the surgical steps. Positioning, surgical complications such as anticipated blood loss or nerve injuries. Duration of procedure, shared airway concerns such as blood, excess, debris, or dislodgement. usage of laser and airway fire considerations, whether there is need for certain hemodynamic or metabolic targets, such as in flap surgery or organ transplantation, electrocautery use in a patient with cardiac implantable electronic device, need for absolute immobility, such as in microsurgery, whether nerve monitoring is used, which may preclude volatile anesthetics or neuromuscular blockers, whether intraoperative imaging is used, such as MRI for neurosurgery, and expected level of post-op pain and post-op nausea vomiting. Pros. This approach directly addresses the needs of the surgical team and optimizes surgical outcomes, and simplifies the planning for straightforward surgeries. However, it may overlook patient-specific factors and risk overemphasis on the procedure at the expense of holistic care. Next approach is the functional or goal-oriented approach. This centers on achieving specific goals for the patient, such as hemodynamic stability, pain control, or rapid recovery. Example of short-term goals includes safe and smooth induction, stable intraoperative physiological parameters, and pain-free emergence. Example of long-term goals includes early mobilization and avoidance of complications such as venous thromboembolism and malnutrition. Pros. This ensures clear objectives are met and encourages a holistic view of the patient's perioperative journey, balance immediate surgical needs with long-term functional recovery. It aligns with ERAS protocol. Cons. This approach may miss details not directly tied to goals and requires team alignment to avoid conflicting priorities. Next is algorithmic or checklist-based approach. This uses predefined algorithms or checklists to systematically evaluate and plan anesthetic care. Example of elements includes use of standardized tools such as ASA classification, airway assessment algorithms, or local institutional guidelines, use of checklists and protocols such as WHO checklists, renal or liver transplant protocols, HIPAC protocols, and protocols for converting labor analgesia to epidural anesthesia for emergency cesarean section. Pros includes reduction of cognitive load and human error. It promotes consistency and thoroughness. It is ideal for less experienced practitioners or emergencies. Cons includes limited flexibility for unique cases and may oversimplify complex scenarios. The next approach is resource-based approach. This focuses on resource availability and limitations, particularly in resource-constrained settings. Example of elements includes planning based on equipment availability, team skills, and facility limitations. Pros includes practical in low-resource or rural settings. It encourages innovation and adaptability, and prevents unrealistic plans. Cons includes this may compromise ideal care and can add stress to decision-making. Next is multidisciplinary approach, which centers on collaboration between the surgical team, anesthetists, intensivists, nursing staff, and other specialties to develop a shared plan. Elements includes shared decision-making, aligning goals and addressing diverse concerns, interdisciplinary input with perspectives from various specialties for complex patients, and facilitates post-op caring, such as coordination of ICU admission and pain management. Pros. This promotes holistic, patient-centered care. It improves communication and teamwork, and encourages comprehensive planning. Cons. Time-intensive and requires team availability. There is risk of conflicting opinions among disciplines. As a conclusion, each approach has its place and can be used independently or in combination, depending on the clinical context, patient characteristics, and institutional resources. A hybrid model often provides the most comprehensive and effective anesthetic plan. In practice, these approaches are frequently integrated to maximize their strengths. For example, an issues-based approach may guide initial priority setting, followed by a systems-based review for a thorough evaluation, and chronological approach to structure planning and care. Other tips in anesthetic considerations: order concerns by priority and probability, and offer solutions with pros and cons for each. Obtain written informed consent and assess patients' capacity for consent. Address patient, anesthetic, and surgical factors. When assessing comorbidities, consider the 3 C's: control, compliance, and complications. When assessing cancer, assess for the 4 M's of cancer: effects of the mass, effects of medications, chemotherapy or radiotherapy. Assess effects of metastasis and metabolic effects, such as paraneoplastic syndrome. Apply appropriate risk scoring. For example, the newly published 2024 AHA Guidelines on Assessing Cardiac Risk. When assessing airway, assess for factors that may increase difficulty for back mask ventilation, LMA insertion, laryngoscopy, E-fauna, and extubation. For NORA, assess the 3 P's and 3 E's: patient, personnel, and procedure, environment, equipment, and emergencies. Always be prepared and have a plan B if the primary anesthetic approach fails, and if the primary surgical approach fails, for example, minimally invasive convert to open, failed manual removal of placenta with need to convert to laparotomy, etc. Discuss with surgeon and cater for their plan B. For analgesia, always consider non-pharmacological and opioid-sparing approaches. For providing regional anesthesia, a useful mnemonic is A-Simples D: assessment, consent, adequate IV access, monitoring, position, preparation, LA and additives, equipment, stop before you block, and documentation. For complex patients, assess whether multidisciplinary input is up to date. For emergencies, determine whether it's a concerning situation or emergency to decide whether to call for additional help. Safety and optimization: mobilize help, scan patient, monitor, equipment and surgery for obvious problems or measurement error, stop the trigger, and stop the surgery if it's the trigger. Stabilize the patient according to ABCDE approach. Assess pulse and CPR if indicated. Administer first-line treatment for immediate physiological derangement, such as fluid boluses and ephedrine for hypotension, FiO2 for desaturation. Diagnosis should follow a probabilistic approach. Rule out serious causes followed by other causes. Avoid fixation error. Apply treatment with crisis resource management principles. List the differentials and treat for each. Stop the trigger. Give antidote. Anticipate and treat end organ complications. And apply prevention measures. Principles for crisis resource management includes: know your environment, anticipate, share, and review the plan, provide effective leadership, ensure role clarity and good teamwork, communicate effectively, call for help early, allocate attention wisely, avoid fixation, and distribute the workload, monitor and support team members. Last but not least, post-crisis management. Communicate with ICU team early if ICU care is needed after the crisis. Thank you.